Okay, you can get started.
Welcome, everybody, to Spine Time, your free webinars with back and neck experts here at Weill Cornell Medicine Center for Comprehensive Spine Care. We come to you every other Wednesday, and we've been doing so since March of 2020. And we thank you for joining us, especially our regular viewers. Today, we're going to talk about something very basic. What is a herniated disc, or what we call a slip of the disc, and what does that diagnosis mean? I'm joined today by my colleagues here in the Spine Center. Just to remind you, the Spine Center is located on 59th and 2nd Avenue, and it's a comprehensive spine program involving spinal surgery, pain management, rehabilitation medicine, and also works with many other departments, including neurology, complementary medicine, and mind-body stress reduction and physical therapy. We have people that you've met in a previous Spine Time, and I'm glad to have them back. Of course, our leader, Roger Hartle, who is the Director of Spinal Surgery here at Weill Cornell Medicine and one of the co-directors of OX Spine at NewYork-Presbyterian. And Dr. Rohan Jotwani, who is an instructor in anesthesiology and one of the new interventional pain specialists here at Weill Cornell. He's been with us for a couple of months, and we heard the two of them have a really great discussion on virtual reality and augmented reality just a few weeks back. So I'm really glad to have them come back here to talk about herniated discs. So welcome, gentlemen. Dr. Jotwani is also currently in the hospital and may disappear for a moment if duty calls to the operating room, but we thank him for any of the time that he has here with us now. So gentlemen, let's start with the basics. If I am your patient, how would you describe what a herniated disc is? And maybe we start with you, Dr. Jotwani.
Yeah, so the way I like to start by talking about it is I tell most of my patients that the spine is kind of like a little house for your spinal cord. And just like every house, it's got foundations and it's got various elements to it. But one of the things that's unique about, the spine is that in order to be a little house that moves for our spinal cord, it has joints and it has padding. And some of the padding between the bones, what we call discs, are basically components. Another way that I sometimes describe it is like a jelly-filled donut, but it's a viscous substance between the bones. And sometimes, when there are little breaks or cracks in that jelly-filled donut, the jelly can come out. And sometimes that jelly can turn that house into a studio apartment, and the spine can get a little mad at that. So it's a little reductive, and there are a lot of metaphors there. But I found over the years that giving people that kind of analogy of, why we have discs, in that they help us move, they act as cushioning between the bones, and what can happen when sometimes those discs have what we call herniation.
Sure. Dr. Hartle, how would you describe it to a patient coming to see you?
Yeah, Neil, thanks for including me today. And thanks, Dr. Jotwani, for this really interesting comparison to the house. And I think it kind of lends itself to that comparison very nicely. Well, if you look at this picture here, you see the bone above, below.
Okay.
You see the the disc, the cushioning, the disc in between, and then you see that, as Dr. Jotwani indicated, that the cushion between the bones allows the movement between the bones, and that's how the spinal column gets its flexibility, of course. And as you get older, sometimes those discs collapse a little bit, and that's one of the reasons why maybe you're less flexible. But what you also see here in this picture is that the yellow part, that's the nerve that goes down into the arm or into the legs. The nerve is right next to that disc. And what can happen, and I think the next slide, if you move to the next slide, that may show nicely and kind of shockingly almost, if you look at the MRI scan,
Right.
what can happen if that disc extrudes, as Dr. Jodwani explained, and then suddenly pushes against the nerve, because then you can get all types of unusual sensations, and they're typically then shooting down the arm if it's in the neck, or shooting down the leg if it's in the lower back. And that can be from numbness, tingling, to irritation, to severe pain, and then also weakness and even paralysis, like foot drop. If it's a big disc herniation and it's pushing on the nerve and it's really compressing the nerve very significantly, and you can see that here on the right side in that cartoon, you see that red portion of the disc herniation, red because it's acute, it's inflamed, it's really pushing into that nerve. And then on the left side, you see an example of a lumbar MRI scan that shows, again, just in the previous picture, it shows the bone, the square of the bone above and below, separated by that disc. And you can see that bulging of that herniated disc that's pushing towards the right, and towards the right is where the spinal canal is and the nerves. And that can cause excruciating pain. And most of us, I mean, most of you probably, and including myself also, have had a herniated disc. And we know how excruciatingly painful and debilitating that can be.
I should also take a moment to remind everyone that while we're doing our presentation and discussion here, we do welcome questions from you. And you can utilize the chat function to do that. And I will do my best to answer your question as we go. This is really great. I guess this lends us to ask the natural question that we probably get asked all the time in our clinic is, does a herniated disc automatically mean that you're going to have pain? Can there be sort of normal findings with herniated discs?
Yeah, not necessarily. The funny thing about spine is that, you know, dealing with spinal problems is that looking at MRI scans is not always a fair representation of how a patient feels, right? We all know that. There are patients who have totally normal MRI scans and they can have leg pain or arm pain or back pain. And there are patients who have terrible looking MRI scans and they may be asymptomatic. That's the problem with what we deal with every day in the office, is trying to identify patients who have abnormal findings on exam, weakness, numbness, tingling, pain, and where there's a correlation to the imaging findings. Because only, for the most part, only if there's a good correlation can you really make the assumption that they're related, and therefore can you come up with a treatment that would entail maybe treating a particular disc herniation and then expecting realistically that that's going to make the patient's symptoms better. So there's no correlation there. Disc herniations, especially if they're disc bulges, you know, a lot of people ask us always, you know, what about disc bulges? You know, that's just a very, very small disc herniation, essentially. A lot of those can be totally asymptomatic.
And nothing to be done, I would assume, right? Or,
you know,
Rohan?
Yeah, exactly. And, you know, there are a lot of studies that look at this and basically say, you know, if you start doing MRIs on people of a certain age, find, you know, if you ask, you shall receive. You know, there are a lot of folks out there, high percentage, you know, above the age of 55 who are walking around with disc herniations, and they have no idea until they do the MRI. So that's one of the reasons why we try and correlate the symptoms the person has with the scan they have. And we just don't treat scans. We treat people with symptoms.
Yeah, well, that's a very good point. And I think that's a philosophy that you know, we're very proud of here at the Spine Center. A question that came up, and you know, to see maybe it's a good time to talk about it. If you go with physical therapy for a herniated disc and you see some improvement, you know, what happens next if things sort of linger? And I guess that let's keep going with our slides to talk about sort of next phases
of care. So we talked a little bit about herniated disc presentation and what people feel. Rohan, talk to us about some of the non-surgical treatments for herniated discs.
Yes. So a lot of the ways.
Actually, give me context for the picture.
Yeah, sure. It seemed like a picture that really showed an essence of like there's a lot of parts to spine care, and there's a lot of things and interconnectedness between the conservative measures that we do and the more surgical methods of helping with herniated discs. But herniated discs, the foundation of conservative treatment starts with activity. So it used to be this notion of you have a herniated disc and stay in bed or become bedridden for a long time. But we know that patients don't do well in those type of states. There's a common saying called, for the back, rest is rust. And if you're already beginning to have degenerative changes like herniated disc, the worst thing that you can do is basically allow yourself to be bedridden for weeks and weeks, and then that rust gets worse and worse. So one of the things that we initially recommend is trialing physical therapy to strengthen the abdomen, to strengthen the back, to tolerate that. Now that's not always true. That's not always the case that people can tolerate that. The pain is really out of control. But along with that, there are medications that we try. Usually we start with over-the-counter medications, and then if folks see us in clinic and they're still having a really tough time, we can start them on, light medications to help with the nerve pain element of herniated discs. And then if all else is, not working out very well and folks are having difficulty even getting to physical therapy because of the pain, a lot of times we intervene with, kind of low-level injections to help with the symptomatic element of disc herniations.
Great. Well, that's really interesting to hear. Let's keep going on our treatment journey.
You want to maybe just why do injections help? What is it about disc herniations? Because the injections don't take the pressure off the nerve.
No,
right?
no.
So maybe that would be interesting for people.
It is a great question, Dr. Hartle. So you're right. And the science, I have to say, the science of why injections work for disc herniations, we're learning something new every day. So initially, one of the key thought processes was, the spine itself and that canal is not really used to seeing the contents of the disc that may be herniating it. And one of the things that comes from that kind of new substance is inflammation. And so one element that we've seen that really helps is decreasing the inflammation, the acute inflammation caused by an acute disc herniation, which is why a lot of our injections contain things like steroids. What's also interesting is that there's this concept that we're learning that beyond just the steroids, it's the actual act of washing and introducing substances, even just saline, can have a better effect on that inflammation that comes during a disc herniation. Now, obviously, if it's a chronic issue and there's a mechanical obstruction, we see people come back ever so often for injections. But many times, the way that I like to talk about it for a patient who's getting an injection with us, maybe the first time, is we're basically helping decrease the inflammation to give the body time to heal itself.
Great. Thanks for sharing that. So now, obviously, there was a question earlier about persisting pain, and there's been a few questions about surgical techniques. I turn it over to Dr. Hartle. When do we consider surgery, and what type of surgery? Walk us through that, please.
Sure. I just want to address one of the comments. It's somebody who has had a disc herniation and has lingering pain, and I want to share a personal story. I've mentioned it before. I had a L5S1 disc herniation, more than 10 years ago, and I had surgery, and the surgery was successful, but that doesn't mean that I'm pain-free. I still have times, especially when I travel, when I'm on a plane for a long time, I'm inactive. Dr. Jadwani talked about resting and rust and rest. If I don't exercise, if I don't do something for a while, I get pain. I get numbness in my right leg, tingling, and I'm always scared, right? I'm thinking, oh my God, I'm going to have another disc herniation. And then I go in the pool, I go swimming, or I do light exercises, and it gets better every time so far, luckily. So I'm just saying that, you can, it's a warning sign. Your body is giving you a warning sign that, you got to take care of your body. You got to listen to your body. And in my case, it's just gentle exercise. I go, in my case, I love swimming. I go running sometimes, and I always get better. But I think that's very important to keep in mind that, recovering from a herniated disc doesn't mean that you're not going to have any symptoms. Every once in a while, you will have symptoms, and it's maybe a good thing because your body's telling you that you got to take care of your body. You got to sleep, you got to exercise, and so forth. Now, how do you know?
It made a big difference for you. Is that fair to say, though, still, the surgery?
Yeah, it made, because I had foot weakness at the time. I had almost like a foot drop, and that's why otherwise I would have gotten more injections and I would have waited, but and that's obviously the topic now. So when consider surgery?
Right.
So when I had my disc herniation, we were in the operating room, we wear lead sometimes during surgery. And for many years, I would wear heavy lead in the operating room. And I would notice that I would get right-sided leg pain every once in a while. And then it was getting worse. And then one day I woke up and I couldn't move. My right foot was almost paralyzed. And I had never gotten an MRI scan, but I could tell from the type of pain that I had the weeks before leading up to this, and then the weakness that I had, I could tell that I had an L5S1 disc herniation. So I got an MRI scan. And then, I'm fortunate because I know a few spine surgeons. So I called one of my colleagues and I told him, look, I haven't gotten an MRI scan yet, but I will get an MRI scan later today. And I checked myself into the into the emergency room. And I told him I will need an operation because I have a foot drop. And that's the time when you should consider an operation. If you have significant foot weakness, and I had significant foot weakness. So that's like a classic indication why, for the most part, you should consider an operation unless you have mild weakness. And if you have mild weakness, if it's barely noticeable, then yeah, you can try steroids and maybe an injection. Physical therapy is not going to help you at that point because you're in too much pain usually to do physical therapy. But if you have significant weakness, and we grade weakness from 1 to 5, and we say if you have a 1 is total foot drop, no movement at all. So if you have a moderate, like a 3/5 weakness, we say that's when you should consider an operation. And in that case, you should probably have an operation earlier rather than later, like I had, and my weakness totally resolved. The other reason why you should consider an operation is if you're a functional person and you've been in severe pain and the cutoff, I usually tell patients 6-7 weeks. If you've had severe leg pain, you can't function, no weakness, but pain, sciatica pain, and you've tried everything, and you still have it after 6 weeks, then I think most surgeons would probably agree after 6 weeks would be a good time point to consider maybe an operation to take the pressure off the nerve and get rid of the pain.
Thank you for sharing your story. I know you have shared it before, but every time you share it, it definitely, really hits home. And I guess, some of the questions that have come up have been, what other things, if your episode happened today and you didn't necessarily have the foot drop, but more of a pain issue, what other things would you have considered trying first?
Well,
I think one of the first questions was, can we put the fluid back where it leaked out?
Yeah, that's a great question. If I had not had weakness, I would have done I would have called you, Neil, and I would have asked for an epidural injection probably, and I would have taken oral pain medication, and I would have waited because there's another question here in the chat room. Do disc herniations heal themselves? And it is true that 95% probably of disc herniations heal themselves. It's a matter of time. And what we do when we say injections, physical therapy, it's really just we're giving nature time to heal itself. And I think that's totally reasonable, and that's the right thing to do, unless you have a red flag, warning sign, and the red flag would be weakness or bowel bladder incontinence, things like that. Sure. But without the weakness, I would have tried an epidural.
Sure. Well, let's keep going through, some of your surgical technique. You obviously are very well published and very experienced in this minimally invasive approaches. Without getting too technical, many people come to us in the spine center saying, I've been told I need surgery and I've been told I need a fusion for what appears to be a disc herniation. Did you have a fusion, and why or why not?
No, I didn't have a fusion because I had a herniated disc that was pushing on one of the nerves. The reason to do a fusion is if you have a different type of pain. Usually patients have more mechanical, like low back pain, not as much leg pain, low back pain, and or they have instability in the spine, which we can usually tell from MRI scan and X-rays. So we do obviously we do fusion surgeries, in patients, but not typically for a patient who has a lumbar disc herniation with sciatica. It would be very rare for those patients to need fusion, but we do. Whatever we do, though, we always try to do the least invasive surgery. And that's typically then, as you see here on this little cartoon, that we go into the spine through a little tube with a microscope, microsurgery, and just remove the part of the disc that's pushing on the nerve. And a lot of these operations now are ambulatory. A lot of these patients really go home the same day. And the advantage is obviously if you do it with minimally invasive techniques is that the infection rate is much lower. There's no blood loss. Overall, probably one of the most successful surgeries that we do in neurosurgery. Lumbar disc herniation, discectomy, I tell patients with about a 90-95% chance of really treating the problem permanently. And but there are some downsides. I'm sure we'll talk about those as well. But for the most part, it's extremely successful surgery.
Great to hear. Maybe a little bit out of order, but I thought we could answer this now is, what about PRP or platelet-rich plasma injections before surgery or after epidurals or part of epidurals? Rohan or Roger, any thoughts on that?
You're muted, Dr. Jadwani.
There are many parts of this country where you will find that folks are trialing things like plasma-rich platelets to help with all kinds of manner of issues. In my own experience, I've seen them be helpful. When I was a fellow in the VA system, we would do them for joints, specifically big joints like hips and knees, and even sometimes shoulders. Now, I don't have much experience with injecting PRP injections into the epidural space or into discs. Folks are doing research on this area. It is actively, being thought of. Are there regenerative therapies that are possible to help the disc kind of gain its sort of center back, for lack of a better way of saying it? And I think the evidence for that is forthcoming. One element to take a note of, though, for PRP injections is, part of the mechanism by which people believe that PRP injections is helpful is that it actually causes inflammation to some extent. And so, I often tell patients who would get it in their joints that your joints may hurt for a little bit. As the kind of inflammation dies down, that you give PRP time to work. I have yet to do it for as a substitute for an epidural steroid injection.
How about you, Roger? Any experience with biologics? Whether that's PRP, stem cell, so forth.
Yeah. So, I don't have a lot of experience using it for back pain patients or for patients independent from surgery. But as you can see on the slide here, we do research for, in relation to biological disc repair and disc regeneration. For example, I work with Larry Bonassa, who's a biomedical engineer in Ithaca at the university. We work on engineering discs that are totally biological, made of your own tissue or culture tissue that you can then put into the spine, especially we're working on the cervical spine, patients with cervical disc herniations, where you can replace the disc instead of putting a cage in and doing a fusion, where we actually insert biological discs. So tissue engineered discs in the lab, custom made for patients. Obviously, this is research. We haven't done this in patients yet, but what we're doing in patients, though, very, very soon is the image below, where we repair an injured disc. One of the things that comes up, and a lot of patients who have discectomies done for sciatica pain, for the herniated disc, the patients will always or frequently ask, well, what about the hole? You remove the disc herniation, and you can see that here in this cartoon. There's a disc herniation that's coming out of the disc. You remove that, and then there's going to be a hole there. And what's the likelihood of disc material reherniating after surgery? And that is a legitimate concern. And studies show that there's about a 5 to 15% chance in patients who have a herniated disc and have surgery, that there's a 5 to 15% chance that they may have another disc herniation at the same level. And so far, there's nothing we can do. There are some companies who have implants to prevent that, but nobody's really using those because patients don't like the idea of having implants, and they're pretty big also. So what we're working on, and that's totally biological, is a biological glue that we inject at the time of the surgery. We remove the disc herniation, and then we inject the glue to seal the defect. And in preparation for that, and this is something we're going to do, we're asking the FDA, currently the FDA, for approval to do this study. And I'm very excited about this. What we're doing already now, though, is in preparation for this study, we're actually injecting stem cells in patients who have a discectomy. And the idea is that, the patients who have a disc herniation, it's clearly a sign of degeneration. So at the time of the surgery, we want to maximize the chances for these patients to prevent degeneration in the future. So we inject their own stem cells at the same time of the surgery into the disc. That's a study that we're doing already. I'm sure there's some of you who are listening may have been part of this. And this is very exciting because it goes a little bit to that question, can you put the juice back into the disc? And that's one of the early attempts that we're doing right now to achieve that, to put cells back into the disc to prevent degeneration from that disc herniation.
All right. Well, we have just a couple minutes left, and I know you guys have done great work on this. Any parting thoughts about herniated discs that you want our audience to know? And I allow you some time for conclusions.
Yeah, I just want to show, there was one slide that I think is one of the most fascinating slides. If you go back to the pressures in the disc, because we always tell patients after the surgery, or in this slide here, because as you can imagine, the likelihood of you developing a herniated disc, or the likelihood of you developing a reherniation if you had an operation or you already had a herniated disc, is related to the amount of pressure that you put on that disc on a daily basis. And this is a study that was done. This was actually a study that was done maybe 25, 30 years ago, where they had volunteers, healthy volunteers, and they implanted little pressure transducers into the disc. They went through the skin and put little transducers into the skin of people. And then they had them do all these maneuvers that you can see here. And this is the pressure that is being generated by these different maneuvers. And you can see here, obviously, the lowest pressure is when you're lying flat. But standing up, and then especially leaning forward, and look at that guy in the middle who is leaning forward and then lifting the suitcase, the pressure goes from a lying position 25, it goes up to 220. That's an incredibly high pressure. And so you can imagine, if you're not careful, if you've got a weak back, you've got a weak disc, you had a herniated disc, or you're at risk. If you do these types of things where you lean forward, and especially leaning forward and lifting, you put a tremendous amount of pressure on your back. And you shouldn't do that, obviously. That's why we tell patients always to work on your posture, keep your back straight. Even if your back is straight, it's 100, which is high, but that's probably acceptable. But as soon as you do things such as lifting things, leaning forward, and look at the guy who's sitting and leaning forward, it's even worse. You put a tremendous amount of pressure on your discs, and you're really risking a herniated disc. And that, I think that's important for patients to know. So always when you're sitting, keep your back straight, exercise, work on your posture against the wall to really minimize the impact that you have on that disc that is at risk of reherniating or herniating.
Great. Rohan, any parting thoughts?
Yeah, I mean, disc herniations are a part of life. They affect so many Americans, so many people around the world, and even being the chief of spine surgery does not mean does not save you from having a disc herniation, apparently.
That was before I was chief.
Fair enough. Fair enough. And for a lot of people, for most people, things will heal over time, right? And so a lot of what we're here to do is help bridge you to that natural healing process. And for the folks that have to live with kind of chronic herniation and chronic pain from those herniations that happened, we are coming up with new and interesting solutions and new research every day on how to help people get better from that. So whether it's something like injections or spinal cord stimulation or surgery, or someday even regenerative therapies, we are all working very hard to make sure that this thing, which is a natural part of our existence, and being a human on planet Earth that lives longer and longer and longer, and we're trying to make it as bearable as possible.
Great. Thank you, gentlemen. It's always fun to have you guys on, and I learn something new every time as well. For those that we didn't get to your questions, my apologies to that. Obviously, you can always reach us by coming into the Spine Center at 240 East 59th Street. The number is here at the end. Oh, I went too fast. I'm sorry. And we hope to join you again in 2 weeks for the next Spine Time. As always, previous episodes of Spine Time will be available and are available on the YouTube site, youtube.com/Brain Spine Center. And thank you, and have a good night.
Bye-bye. Have a good night. Thanks.
Bye.